Good afternoon, everyone. This is Carrie coming to you from Lakeview Health. I'm excited to be with Debbie Feigel today. We're going to be talking about substance use disorders and an overview. And just to get started, I wanted to go through a little bit about Lakeview Health. We are a dual diagnosis treatment center. And like I said, we are here in Jacksonville today. We do also have another location out in the Woodlands, Texas, which is just slightly north of Houston. And in our Jacksonville facility, we are gender responsive, meaning that men and women are working on recovery in separate facilities and using curriculum and programs that are designed for each gender's unique needs. We do offer a continuum of care from medically monitored detox all the way through intensive outpatient programming. Our board certified physicians partner with our licensed and master's level clinicians to develop comprehensive and individualized treatment plans to help people set a new course in health and recovery. In the Woodlands, we offer a partial hospitalization program as well as day and evening intensive outpatient programs. They do weekly yoga to help the patients really with their overall wellness. As a whole, Lakeview Health really believes in helping people heal their whole self, so mind, body, and spirit. Our facilities are licensed in their respective states, as well as both hold the gold seal of approval with the Joint Commission, and we maintain membership with both the National Association of Addiction Treatment Providers and the National Association for Behavioral Health Care. So that's a little bit about Lakeview. Moving on to today's webinar, we have a couple of housekeeping items. We do welcome questions, so please, in the question panel on your screen, please type in your questions and we'll get to those at the end of the webinar. We also do appreciate your feedback. About 60 minutes after the webinar concludes, we will send out an email that has a post-test and an evaluation. If you could complete both of those, that would be great. The feedback really does help us know how did we do today, as well as what do you want to hear about in the future? What can we help you learn more in-depth information about? Our upcoming webinars are April, we'll be talking about personality disorders and addiction, and then in May, we do have integrating self-help into treatment, a crash course for clinicians. So I will hope that you can join us for one of those as well. Moving on to today, I am so excited. Debbie Feigel is here today. She has been working in the medical field as a certified physician assistant for 30 years. And for the past 8, she's really focused in the addiction medicine area. Prior to working in this area, she was working in Mayo Clinic in Jacksonville for 20 years. So she has a ton of great experience. I think that she'll be able to provide to you and what you're doing in your practices around what are substances and how can you screen for those, and answering any of your questions that you have too. So with that, I am going to turn it over to Debbie. We're just going to change seats.
Hello, everybody. Today, what I'm going to do is provide a lightning fast overview of substance use disorders. And what we are going to do is first define substance use disorder, understand the disease model of addiction, which I will cover very quickly. I have an entire lecture on that alone. Identify the tools for screening and evaluating substance use disorder, and then we're going to go over the DSM-5 criteria for substance use disorder and the 6 dimensions of the ASAM multidimensional assessment. This is important for us because when we bring people into treatment, all of this criteria has to be met when we first evaluate the patient. I do not have any disclosures. So you'll see many definitions of addiction, and probably the best is the ASAM definition, that addiction is a primary chronic disease of the brain, reward, motivation, memory, and related circuitry. Dysfunction in these circuits leads to characteristic biological, psychological, social, and spiritual manifestations. And I think what is important here is it is reflected in an individual pathologically pursuing reward and or relief. Relief is important here because prior definitions really only used pursuing reward. And we'll go into that in a little more detail. But very, very many patients that come in with addiction are actually using the substance for relief. Often of mental health disorders they don't even know they have. Anxiety, depression, mood disturbances, particularly bipolar disorder. Up to 65% of patients with untreated bipolar disorder will have addiction problems, trying to stabilize their mood, even though that's done subconsciously. And it's characterized by the inability to consistently abstain. I think one of the saddest things that I have ever heard is the pain in some of these people that say they desperately, desperately, desperately want to stop using, but are unable to do so. And we'll talk about the brain and the circuitry and why that actually happens. And addiction involves cycles of relapse as characteristic of really any other disease. And we think of often addiction relapse as something to be ashamed of when actually the relapse rate for primary treatment of asthma, hypertension, and diabetes has just about the same relapse rate. And without treatment, addiction is progressively fatal without treatment. So according to SAMHSA, we classify substance use disorder as mild, moderate, or severe, and we'll go into that. This occurs with recurrent use of drugs or alcohol, clinically and functionally significant impairment. And I think we're all familiar with that. Health problems, disabilities, failure to meet work responsibilities, school responsibilities, or home. And it's characterized by lack of control, repeated use despite negative consequences. I think that's a hallmark. You'll see people with multiple problems associated with addiction, and they continue to use despite this. Also, risky use, driving while intoxicated, working while intoxicated, taking care of children while intoxicated. I don't need to belabor this point, but the costs are huge in this country. $740 billion plus annually in costs related to addiction. And this really doesn't even include the increased amount of treatment availability that we need and medication-assisted therapy, which our government is pushing now for opioid addiction. I think it's important to note here that of every 10 people who actually seek treatment for addiction, only one of those, so 1 in 10% of people actually receive treatment that they need in this country. And that's mostly due to cost and availability. So the synthetic opioid addiction or the epidemic, looking at basically these statistics are for fentanyl. It's huge, absolutely huge. In fact, Duval County, where we are located, has the highest rate of overdose deaths for fentanyl in the entire state. And 72,000 people died of drug overdose in this country in 2017. And on the right, you can see that is compared with gun-related homicides, 40,000 vehicular deaths, almost 80,000 diabetes deaths. And in the red, because my background was developing and managing the multidisciplinary breast clinic at Mayo Clinic, I have a lot of background in breast diseases and breast cancer. And in this country at this time, less than 40,000 women will die of breast cancer. And that number goes down every year. That's still too many, mind you, but what I want to contrast and compare is that if a woman is diagnosed with breast cancer today, she has a 90 to 95% chance of being cured of the breast cancer. Conversely, someone diagnosed with addiction, alcoholism, heroin addiction, has up to a 90% chance of dying of their disease, whether they achieve recovery or not, which is the exact opposite. And we can just look at the funding and the awareness around breast cancer as opposed to addiction. So we talked about addiction taking place in the reward part of the brain. This is a primitive part of the brain. It's actually the midbrain, and it develops before the thinking part of the brain, or the frontal cortex. And it's meant to really override that frontal cortex because it's there for evolutionary purposes. So in order to perpetuate our species, we have these essential things: food and water, sex to procreate, and pass along our genetic material, community and social. Humans are social animals, but social community also provides safety. People that were out living in caves on their own in ancient times were eaten by saber-toothed tigers. So banding together was important. Nurturing, taking care of your children until they can be raised to adulthood and then pass on their genes. And of course, sleep we know is essential and is a primitive drive. And just to illustrate how strong these drives are, we think we have control over all of this. But if anyone remembers the Donner Party in the late 1800s, or the book and movie Alive, the rugby team that crashed in the Andes, what did they do when they were starving? They cannibalized each other, excuse me. They cannibalized each other to survive. And for almost all of us, cannibalism is against our morality. But that drive to survive is so powerful that it hijacks that morality in the frontal cortex. The problem with addiction is that it actually takes place in this part of the brain, and it gets roped into that evolutionary pathway. And the brain actually begins to interpret that substance as necessary for survival. And the difficulty is that, like I said, there isn't much backward control over that from the frontal cortex. And that drive will actually hijack that frontal cortex to get the substance that's necessary for its survival. And this takes place largely below the level of consciousness. Now, that doesn't mean that people with addiction are not responsible for their behaviors. What it does is it explains why people will do things that they would never ever do except for the addiction, and why they keep doing it despite these negative consequences. And like I said before, people who don't want to do it anymore but cannot stop. What also happens is that there's less pleasure for those natural rewards. So this takes place in what we call the dopamine system, although there are other neurotransmitters involved in addiction, and the next slide will speak to that. But the natural rewards that are given for these evolutionary things, such as eating a good meal, provides pleasure. Sex obviously provides pleasure. We feel good when we get a good night's sleep. That feeling that we get inside when we hug our children or hug somebody that we love, that little bit of tingling that you get, that's actually dopamine. And the brain likes that. So we keep doing that because it feels good. The substances involved in addiction vastly outweigh that dopamine. And therefore, that's why you see people who don't care about their families anymore, don't pay attention to them, lose touch with their children, stop eating, don't pay much attention to sleep or themselves. And that's because those natural rewards aren't nearly as powerful as the dopamine surge they get from their drug of addiction. So like I said, dopamine is involved in most drugs of addiction. However, there are many other neurotransmitters involved, including serotonin, other endorphins, GABA receptors, and glutamate, very important in alcohol, acetylcholine for nicotine and alcohol, possibly marijuana, anandamide for marijuana. And these drugs can mimic, augment, or prevent reuptake of the neurotransmitters. And just to kind of give you a visual example of what that looks like, anandamide is over on your left. That's the chemical structure. THC, the active ingredient in cannabis, is on, anandamide's on your left, THC is on your right. They look very similar. And the brain believes THC is anandamide, and that's what causes that intense reaction in the brain. Many addictive substances. I don't need to go over this. I recently gave a talk on synthetic drugs only, and the list of synthetic drugs available are easily twice as long as this list and being developed every day. So how does addiction occur? It's very multifactorial. What we've learned is that biology plays a huge part. If someone has a first or second degree relative with addiction, penetrance of the genetics can be up to 40%, which is very high. Couple that with environment, so a chaotic home environment, peer influences, an addicted parent at home, and many other environmental influences. Coupled together with the drug actually plays a role in its addictiveness. So if you look at alcohol versus heroin, the addictive potential in those differ. It's much higher for heroin than it is for marijuana. Also, the route of the drug, the cost of the drug, something that's cheap and available is going to be more highly addictive. In fact, nicotine is one of the most addictive drugs on the planet. There are some brain mechanisms that we don't clearly understand, and this in combination leads to addiction. So how do we screen for this? Well, probably the most common tool that we've heard of in the primary care setting, and even in the hospital setting. I give this lecture a lot for people who work in the hospital to identify substance use disorders very quickly in the emergency room. SBIRT, which we'll go in more detail about, means screening, brief intervention, and referral to treatment, and the CAGE and the CAGE aid. The only difference is the CAGE aid includes drugs as well as alcohol. So again, the SBIRT has the 4 components: the screening, the brief intervention, and there's actually brief therapy in there, which I'll go into, and the referral to treatment. And we just talked about this. So SBIRT affords early intervention for substance use. Risky or even low-risk substance use can be identified in the primary care setting. And referral to treatment in moderate to severe cases of drug and alcohol misuse can be referred to appropriate people early on before we get to debilitating conditions. And looking at the pyramid, the referral to treatment of all people screened ends up being about 4% of people screened, but I want to emphasize the pyramid only represents alcohol. So coupled with drugs and prescription drug misuse, it's probably much higher. This is just a testimonial from a health educator performing an SBIRT on a patient that basically just illustrated for the patient how much he was spending on alcohol, which amounted to $320,000 over the course of 20 years. Now that's an eye-opener. So SBIRT can be performed by really any healthcare provider. It's also reimbursable. However, if it is to be submitted for reimbursement, the person performing it and submitting it needs to be licensed by his or her state agencies. Can be performed really in any healthcare setting. And I don't need to belabor this, but for reimbursement, as with any other medical interaction, needs to be well documented and supported. If you do submit it for reimbursement, the ICD-9 and CPT codes are available on the SAMHSA website. So the screening is the assessment of the patient for risky substance use and behaviors. And what's important in this is you have to use validated and standardized screening tools. So on the outside, SBIRT looks like it's very quick. Ask a few questions, give a brief intervention, referral to treatment if you're worried it's severe. Should only take about 10 to 15 minutes. That's probably true where it's used consistently and all the time, but it can be cumbersome. And the reason why it can be cumbersome is these validated standardized screening tools. And we'll go over them. These are some of the validated screening tools that you can use for SBIRT. There's also others. The ones I will go over are the Audit, the DAST, the Assist, and the GAIN. Briefly, POSIT and CRAFT, and others are for really adolescents and children, and you can find those on the internet. You'll be looking at, in some of the following slides, the actual forms that are used for many of these screening tests, and patients can actually take them themselves. They're not something that has to be administered for the most part, but can be handed to a patient and then the results tabulated and go from there. And that makes really the SBIRT a little more streamlined if that's done. So when we're talking about audit, which is for alcohol, we have to know what a drink actually is. And it's not as much as one might think. And on the left, you'll actually see how much an actual drink is when we're comparing beer, malt liquor, table wine, or spirits. Of note, I don't know if anyone's ever heard of Four Locos. I don't even really know what it is, but some type of malt liquor. It's sold in 24 to 48 ounce cans, and it contains 12% alcohol. So we have patients come in saying that they drink 3 or 4 Four Locos a day, and you think, well, that's beer. Well, it really isn't. It's like drinking 3 48-ounce cans of wine as far as alcohol content. On the right, maximum daily limits, and research is showing over and over again as we move forward that really fewer drinks are better when it comes to alcohol consumption. So this is an example of a shot of what the screening test would look like for audit. I don't need to go over this in detail. You can look at this. Are they going to get copies of the slides? Yes. Okay, you will have copies of the slides. And like I said, all of these screening tools are actually available online and can be printed out. So basically, this asks a number of questions about alcohol use. A score of 8 indicates hazardous use, so you'd move on from that and do your brief intervention or referral to treatment. Again, this is one of the self-reports that can be given to a patient. DAST applies to drugs, so really when we're talking about SBIRT, we need to be doing both drugs and alcohol. So if we're using Assist, we need to use DAST as well. Very same format, yes or no, on multiple questions about drug abuse, and 6+ indicate harmful use, and 11+ indicate some type of substance use disorder. The Assist actually is very comprehensive. It goes over drug use, alcohol use, and actually includes smoking. And what it does is it starts with questions, yes or no, do you use these substances? And then it goes over each substance in detail, asking questions. So it goes over tobacco, alcohol, cannabis, cocaine, amphetamines, and so on. Have you used in the last 3 months? How often do you use if within the last 3 months? And then for each drug that the patient admits to using, there's questions on this questionnaire. In the end, it's all added up and gives you a score and whether to be concerned. And the score is for each substance that the person admits to using. The GAIN S includes behavior, mental distress, and crime or violence. This is something that we see usually later in substance use, but can present very early on without many of the other signs and symptoms that you see with drug and alcohol abuse. So with the brief intervention and brief therapy, it's estimated that only about 15% of screenings in primary care require a brief intervention or brief therapy. So for those determined to be at low risk, what we want to do is similar to the healthcare testimonial that you saw earlier, is educate this person about how much they're drinking or using and what those risks are moving forward. With low-risk individuals, this can be followed up on whatever timetable that a primary care physician sees a particular patient. Now, with those determined to be at moderate or high risk, estimated to be about 4% of screenings, brief therapy is recommended. So we do the brief intervention, educate, and we want to bring them back on several occasions, not too far apart, maybe every month, to talk about this. Or we can refer them to a therapist or someone else that can discuss their high-risk use. And they can go over, or we can go over, education, again, problem solving, coping skills and strategies, how to have a supportive environment, and encourage shift in thinking. Obviously, a referral to a self-help group such as AA or NA really is appropriate here. For high risk, or those that meet criteria for substance use disorder, which we'll talk about in just a minute, we really need to facilitate access to a specialty provider, whether that's for more detailed assessment or for inpatient, outpatient residential treatment. The cage aid I like a lot because it's very simple, and if anyone has ever seen the pamphlets that AA gives out screening for alcohol, several of these questions are on that screening for AA, and it's very simple. Do you drink alcohol, yes or no? Have you experimented with drugs or taken prescription drugs, yes or no? For yes questions, or for yes responses, have you ever thought you needed to cut down, which is the C? Have you ever annoyed or been criticized for drinking or drug use? That's the A. Have you ever felt bad or guilty, ashamed about your drinking or drug use? That's the G. And have you ever taken drugs or alcohol in the morning to start your day? And that's the eye opener, or E. Any yes response in the last four questions is considered positive. And I think that when I talked about SBIRT being a little cumbersome, that this is really an easy first step that can be administered to any patient in any setting. And with a yes response, one could proceed with a more in-depth SBIRT screening, referral to treatment, or brief therapy. This is a testimonial about a patient becoming aware of alcohol use, and this was done, this happened because of SBIRT screening in the primary care setting. You can read that on your own. And in the bottom box, I think this is very important because for every dollar we spend, we save $4 in substance abuse treatment. And that's because of productivity, healthcare cost savings, and many other things. But this is very well documented. Unfortunately, insurance companies have not caught up with this because at least pretty much across the board, the healthcare insurance industry tends to limit spending for addiction treatment. So additional considerations. So in addition to the SBIRT, that really isn't the whole picture. And unfortunately, there's much shame and guilt involved with addiction, and patients will lie, they will minimize, deflect, and deny that they have any problems. So we really have to look at the whole picture. So there are other red flags to look at. Let's start on this slide. So we look at general signs of addiction. There are many things we can look at. Obviously, taken alone, many of these signs and symptoms could be indicative of something else. But if we look at the whole picture, we see a change in the person's demeanor. They will no longer be the person that you had been seeing before. So they may be more aggressive, more irritable. Their personality may change. They may be very anxious, very depressed, may start having panic attacks just out of the blue when it seems like nothing else has changed. Very lethargic, changes in habits, possibly criminal activity. Getting a DUI is an indicative indicator of possible substance use, abrupt weight changes, sleeping or sleeping too much, and particularly for those providing prescriptions for potentially abused substances, lost prescriptions, running out early, asking for higher doses. This doesn't necessarily mean the person may be addicted, but it is a warning sign. So going into drug classifications, I think it's also important that we know the signs and symptoms of how someone looks intoxicated on these substances, because like I said, there are many excuses and denials that will come from a person. This is very important in the acute care setting, urgent care setting, because patients may look intoxicated and present all the symptoms but say that they're not drinking or not using drugs. So we have to look beyond that and know briefly some of the signs and symptoms of using particular substances, including the depressants, the stimulants, hallucinogens, designer synthetics, and the inhalants. And we'll go over this in a little more detail. So we're going to look at intoxication of withdrawal in alcohol, sedatives, cocaine or amphetamines, cannabis, and opioids. So with alcohol, I think everyone pretty much knows what an intoxicated person looks like. They have slurred speech, they tend to be drowsy, they're unsteady, strong smell of alcohol, impaired coordination, and of course the following. Also, we'll see physical manifestations, often sweating, and increased blood pressure or pulse. So withdrawal occurs, we don't need to belabor this too much, occurs 6 to 24 hours after the last drink and can occur before blood alcohol level reaches zero, particularly in chronic heavy drinkers who are used to having a high alcohol level. They may start going into withdrawal at 2 or even 3 times over the legal limit. Seizures, that's important. We often see here, people will come in and say they have a seizure disorder, but when further questioned, the seizures occur from withdrawal from alcohol or benzodiazepines, which is where seizures occur in those 2 particular situations. DTs, obviously, if anyone knows what DTs are, that's severe agitation, confusion, hallucinations, and the mortality rate is actually very high for people that experience the DTs. Wernicke's encephalopathy. You know, up until this last year, I really did not see many people with Wernicke's encephalopathy, which occurs really at end-stage liver disease and really people on the edge of liver failure due to alcohol use and or actually IV opiate use with hepatitis C. But just in the last month, I have had 2 women and 3 men here being treated that actually have Wernicke's encephalopathy. And unfortunately, it can be permanent. So the encephalopathy that happens due to this may not be reversible. So sedatives and hypnotics, actually very, very similar to alcohol intoxication, and that's because sedatives and alcohol use almost exactly the same receptors and neurotransmitters in the brain. With sedative use, probably the biggest difference is memory loss. whereas alcoholics can have blackouts that may last for several hours. If they keep drinking excessively, may last for several days. It really does not take much benzodiazepine use to see impaired memory that may last several days following even discontinuation of the substance. And this slide really indicates, and something you have probably heard or at some point will be told, I took my prescription exactly as my doctor told me to. That doesn't mean that there isn't a risk of addiction or withdrawal. In fact, looking at oxycodone use, people who use oxycodone regularly for 2 weeks or so will experience some type of withdrawal symptoms when they stop using it, and that's really remarkable. Many people, once they have used oxycodone for a period of time for pain, will keep taking it to avoid withdrawal symptoms. So withdrawal signs for sedative and hypnotic use, seizures are a really big indicator. Otherwise, it really looks a lot like alcohol, high blood pressure, tachycardia. More marked than alcohol is agitation, extreme anxiety, rebound anxiety. We don't think of sedatives as increasing anxiety, but they actually do, because they prevent the person from utilizing other coping skills with anxiety, and they develop a tolerance to it. And anxiety over time actually goes up. And that's why sedatives are such as Xanax or Ativan or what have you. If you really look at their indications, they are not indicated for chronic use, and that is because of the dangers associated with it, not only withdrawal and seizures, but because it actually worsens the symptoms that you were trying to treat in the first place. That's why these medications should only be used in the acute setting. Unfortunately, that's not usually what happens, but these are the problems that result from chronic use. So the cocaine and stimulants, obviously dilated pupils, restlessness, they tend to lose a lot of weight over time, sweating, hyperactivity, sometimes mania, picking, sometimes psychosis. We see psychosis with methamphetamine. It's actually very common. Withdrawal, the most marked thing that we see is fatigue. They can sleep for days and days and days, fall asleep while they're talking to you, be very irritable, and on the flip side can also have insomnia and depression. Cannabis, this is a subject near and dear to my heart because I have a family member that developed an addiction to cannabis. This is not a benign drug, contrary to what a lot of people think. And a study actually just came out yesterday looking at cannabis and the cannabis that we have today. It's not the cannabis of 30 years ago that a lot of us smoked on occasion that had about 3 to 4% concentration of THC. This cannabis has 15 to 20% concentration of THC, and the products such as the wax and the oils that are used in vaping up to 98% THC. So the product that's being used now on a regular basis, there has been probably a causal effect with particularly young people developing psychosis and psychotic disorders that may or may not be permanent. We pretty much know what people look like when they're high. There is withdrawal from cannabis, nausea, sweating, tremor, fever, chills, headache, restlessness, poor appetite, anxiety, irritability, and down at the bottom on the left, cyclical vomiting and nausea. We're beginning to see a lot of this. It used to be called cyclical vomiting syndrome. Now it's called cannabis-induced hyperemesis syndrome. And we're seeing much more of this, and it's induced by the cannabis. So we think of medical use of marijuana for the person with stage 4 cancer who can't eat anything, who's chronically nauseated. A little bit of cannabis actually relieves anxiety and relieves nausea and improves appetite. The opposite is true with chronic use of these high-dose cannabis products, and people can develop cyclical vomiting. And it's a very, very difficult problem to treat. With the opioids, which is in the forefront of addiction these days, opioid intoxication, we see constricted pupils, they're drowsy, they're euphoric, they're confused, impaired memory, they can't walk straight, they will have a low blood pressure and pulse. Constipation actually is a hallmark. People using opioids chronically will develop very severe constipation because of the effects of the opioid on the gut. Also respiratory depression, and unfortunately, sometimes the only sign we see of opioid intoxication is death, overdose and death. I want to speak just briefly about opioid overdose because it is a public health crisis at this point, and it causes respiratory depression. Often you will see needle tracks on a person that may be passed out. The triad is coma, respiratory depression, and excessively constricted pupils, but most people don't exhibit all of these. So a brief mention of Narcan. Narcan in most states, including Florida and Texas, where we have facilities, is available over the counter. You do not need a prescription. Many insurance companies actually will provide it free. And this is not just for people who may have someone who uses opioids in the house. This is really for anyone to carry. Now, Narcan or naloxone will not harm anyone. The only time that you really don't want to use it is in a newborn baby. But we are recommending now, and many emergency units are recommending that if it's available and you see someone who is passed out on the sidewalk, no matter what the cause, that Narcan should be administered. And this can be given by anyone. So withdrawal symptoms from opioids, and the most prominent are muscle aches, chills, sweats, marked anxiety or depression, and GI distress, nausea, vomiting, abdominal cramps. These people are very, very uncomfortable, and that's why many revert to using again to prevent these symptoms. Toward the end stages of addiction, no euphoria is gained from using the drug, and the drug is only used to prevent the side effects of withdrawal. And again, what opioid withdrawal symptoms look like. So the DSM-5 criteria, that is what we use to evaluate and determine the severity of substance use disorder. So once a referral is made to us, these are the tools that we use. So American Society of Addiction Medicine utilizes 3 dimensions. Dimension 1 looks at acute intoxication or withdrawal potential. That's where we look at each drug of addiction and determine severity of use. We also use Dimension 2, which is biomedical conditions, Dimension 3, emotional and behavioral, readiness to change, Dimension 5, relapse, continued use, and recovery or living environment, because all of these things affect how we treat an individual and the severity of their use. Now, more specifically, Dimension 1, these are the drugs that we evaluate. Tobacco is actually included in Dimension 1 in the DSM-5 criteria. So this is the DSM-5 criteria for Dimension 1. And there are 11 things that need to be answered, or 11 areas that we look at when we're evaluating the severity of substance use. The first is the substance taken in larger amounts or over a longer period of time that was intended. I saw a study in the last several years that looked at people taking opiates, specifically oxycodone, for acute pain. And I talked about that, that even after 2 weeks, withdrawal symptoms can develop. And it looked at people that were using oxycodone 3 months after their original injury for whatever that was. In adolescents, I often see they get oxycodone, having their wisdom teeth out, having a fracture, they're given oxycodone, recovering from a minor surgery, have oxycodone. Oh, I did something here. Oh, there we go. If they're still using the substance at 3 months, 50% of them will still be using the substance at 3 years, and in much larger amounts. So a persistent desire or unsuccessful efforts to cut down, a great deal of time spent in activities necessary to obtain the substance. Craving is a sign that really is specific to addiction, and craving doesn't only encompass craving to use the drug. Craving also implies to a person not being able to stop using. So for instance, an alcoholic who may have been in recovery for 10 years, has no desire to use alcohol, absolutely no craving, but if they take that one drink, the craving is started and the obsession to drink again becomes triggered, and very few alcoholics can stop drinking even after a single drink because of that phenomenon. So recurrent use resulting in failure to fulfill roles at school, work, or home. And I underline number 6, and I've mentioned this before, continued use despite negative consequences. And we see that all the time. People will land here because their marriage is in ruins, their children won't talk to them anymore, they've lost several jobs, but they keep using. They've been arrested for a variety of disorders or multiple DUIs, and they keep using and drinking. Social, occupational, and recreational activities are given up. Use of the substance in hazardous situations, i.e. drinking and driving. Substance use continued despite having a knowledge of physical and psychological problems. So these people that I've seen with Wernicke's encephalopathy have known that they were very sick and their livers were very sick, but they kept drinking despite that. Tolerance, larger amounts of the substances are needed to achieve the desired effect, and withdrawal. So characteristic withdrawal by whichever substance they're using. And so we have those 11 things that we look at. Mild substance use disorder is 2 to 3 symptoms, moderate 4 to 5, and severe is 6 or more. And this is how we determine what type of treatment is necessary. Again, we usually disagree with insurance companies, but people with severe substance use disorder usually require residential level of care. Moderate and mild can be treated at lower levels of care, such as IOP or PHP, but people with severe use disorder really need some level of inpatient residential treatment. So, and we can't forget other addictive disorders when we're looking at substance use disorders and qualifying the degree of impairment. Really, addiction, when we look at it from the brain standpoint, is the brain wanting to change its mood. So basically, quote, I don't like the way I feel and I want to change my mood. And people with addiction are driven to change their mood. If they feel good, they want to feel better. If they feel bad, they want to feel good. If they're anxious, they don't want to feel anxious. If they're depressed, they don't want to feel depressed. So this doesn't just happen with drugs. It can happen with what we call process addictions. And of those process addictions, there are many and include gambling disorders, sexual addictions, shopping, eating disorders, food addiction, work addiction, addiction to chaos, and anger and rage. So there are multiple. And of note, gambling disorder is actually recognized by the DSM-5 as an addictive disorder. The other are not. So dimension 2 is where we look at medical conditions associated with the addiction, and this is important when we're doing our evaluation. And they include disorders that are caused by the substance use, hypertension, liver disease, endocarditis with IV use, and infection, diabetes, DTs, seizures, a brain injury, paralysis, co-occurring medical issues as listed. Mental health disorders. We know that mental health disorders run hand in hand with addiction, and that up to 80% of people with addictive disorders will have associated mental health disorders. Suicidal ideation, past and present, and previous attempts are very important in this section. Readiness to change, is their motivation internal versus external? I can tell you that probably 99.9% of people coming into treatment are externally motivated. They want to get better for some reason other than they personally just want to get better. What is their insight, their judgment? Do they have ongoing enabling? Do they think they've hit rock bottom? Dimension 5, what is their relapse potential very quickly? How many treatment attempts? How long have they stayed sober? Have they participated in self-help groups in the past? How has their use escalated or changed? And on and on. Dimension 6 looks at their current living situation. I can tell you quite a few patients that come in are not in a stable living situation that will support their recovery, and this is also important in determining substance use. So very briefly again, this is a look at the 6 dimensions of the ASAM criteria, and with that, I'm going to open it up to any questions.
Great. So thank you so much.
Mm-hmm.
Very informative, and like you said, very fast.
Mm-hmm. Very fast. Lightning speed.
If you do have questions, you can go ahead and put them in the question box in the panel on your screen, and we will get to those. As you're typing in questions, I'm just going to go ahead and remind you, concluding this webinar, you'll get an email with a post-test and an evaluation. And we would really appreciate you completing both. We'd love to know what you thought about today's presentation and all of the information that Debbie was able to present. We really hope that it was helpful and you'll be able to use it in your practice. So waiting on questions here. I think that you may have just covered everything.
Well, you know, that's okay. And I have to apologize if I seem a little bit awkward. I'm actually used to speaking in front of live audiences, and I gesture and I like to involve the audience during the talk and asking questions, and I walk around a lot. So sitting here and looking at a camera is a little difficult for me.
All right, well, I don't see any questions coming up, so
well, I'll turn it back over to you.
Let's see, we've got one. One moment. What type of drug causes sores on the face?
Yes, very good question. That is associated with methamphetamine. It can also be associated with cocaine, but more commonly the stimulants, amphetamines, and specifically methamphetamine, because what it does is it causes agitation, and it makes the skin feel like it's crawling, and also hallucinations that they may have bugs under their skin or something is on them, and they pick their skin incessantly.
Thank you. Mm-hmm. All right. Well, we are going to wrap it up again. Thank you so much for taking the time to be with us today, and hope that you can join us in either April or May for our upcoming webinars. And have a great afternoon. Thanks so much for joining us.